All right, everyone. Have you ever really thought about what happens after you swallow a pill? Today, we're going to follow that medicine on its incredible journey through the body. We'll see how one tiny tablet can figure out exactly what to do. So let's get started. This is the classic question, isn't it? You've got a throbbing headache, you pop a pill, and somehow the pain just vanishes. But how? How does that tablet know the pain is in your head and not your foot? Does it have a tiny little GPS inside? Well, the answer is a little more interesting than that. The simple answer is, it doesn't know. That tablet actually goes on a tour of your entire body, and the science of that journey has a name, pharmacokinetics. Now, this diagram you see here, this is our map for the whole trip. It shows the four main stages: absorption, which is getting into the blood; distribution, traveling around; biotransformation, how the body changes it; and finally, excretion, the exit plan. Just remember the acronym ADME. This is our guide for today. So, for any journey to begin, our drug has to first get inside, right? It has to cross the most fundamental barrier in the body, the cell membrane. This is its first great challenge. And this is that wall, the cell membrane. Just look at its structure. It's mostly a fatty layer, what we technically call a lipid bilayer. And you see those things embedded in it? Those are special proteins. Some of them act like little gates or channels that can let things pass through. Think of it like a fortress wall with a few very well-guarded entry points. So, the big question for our drug is, how do I get an entry pass? How does it cross this heavily guarded wall to get to the other side? Well, turns out there are a couple of ways. The easiest way in is for drugs that are lipid-soluble, basically drugs that like fats. Since the membrane itself is fatty, these drugs can just dissolve right through it. Simple, nah? This is called passive diffusion. It doesn't need any energy. The drug just moves from where there's a lot of it to where there's less of it. It's like coasting downhill on a bicycle. But what if a drug isn't fat-soluble? Then it needs a special invitation, a VIP entrance. And that's where those protein gates come in. They act as carriers. Now look at diagram A. Here, the carrier just helps the drug move along. No energy needed. We call this facilitated diffusion. But in diagram B, you can see it's different. The carrier actually uses energy, ATP, to actively pump the drug across. This is active transport, and it's like using a motor to go uphill. So it's really important to understand this difference. On one hand, you have passive diffusion. For fatty drugs, no helper needed, just follows the crowd. On the other hand, you have carrier-mediated transport, which needs a specific protein helper. And because you only have so many helpers, the system can get busy or saturated. It's also very specific, like only one key opening one lock. But wait, it's not just about being fat-soluble. The drug also faces a kind of identity check based on the chemical environment it's in, and this is what we call the Great pH Challenge. To understand this, we need to know about something called pKa. Think of it as a drug's chemical personality. It's the exact pH where half the drug molecules have an electrical charge, we call that ionized, and the other half are neutral, or unionized. And trust me, that charge makes all the difference. This picture explains it brilliantly. Look, a drug can only cross that fatty membrane when it's in its neutral unionized form. So here, it crosses from a pH of 5 to a pH of 7. But once it gets to the other side, the new pH makes it change its form. It becomes ionized or charged, and once it's charged, it can't go back, it's trapped. This amazing phenomenon is called ion trapping. So if you remember only one thing from this whole section, make it this. This is the golden rule of pharmacology. For a drug to pass through that fatty wall, it must be in its unionized, lipid-soluble form. This is absolutely key. Okay, fantastic. Our drug has figured out how to cross the first barrier. Now it's time for the next big step in its grand tour, actually getting into the body's main transport system, the bloodstream. This stage is called absorption. Now, absorption isn't always so straightforward. A lot of things can affect it. For instance, a drug needs a huge surface area to be absorbed well. That's why your intestines, with all their folds, are so much better at this than the stomach. And of course, you need good blood flow to the area to whisk the drug away and keep the absorption going. This brings us to a very practical and important idea called bioavailability. We usually just call it F. Bioavailability is basically the report card for the absorption process. It tells us what percentage of the drug we took actually made it into the bloodstream, ready to do its job. This graph here really shows bioavailability in action. Look at curve A.
The drug gets absorbed quickly, and its concentration in the blood shoots up into the effective therapeutic range. It works fast. Now look at curve B, much slower, right? And poor curve C, not enough of the drug even gets absorbed to be effective. We would say it has very low bioavailability.
Excellent. So our drug is in the blood. Mission accomplished? Not at all. The journey is far from over. Now it has to travel through the body's highways to get to the place where it's actually needed. This is the distribution phase. You see, just being in the bloodstream is like getting onto a massive highway. You're moving, for sure, but you're not at your destination. The drug now has to navigate this whole network and find the right exit to reach its target.
And there can be traffic jams on this highway. Many drugs like to hitch a ride on big proteins floating in our blood, like albumin. But here's the crucial part. While the drug is bound to the protein, it's inactive. It's just a passenger. Only the free, unbound drug can actually leave the highway, cross membranes, and have an effect.
This brings us to the most difficult destination of all. How does a drug get into the body's high-security command center, the brain? This slide shows the challenge perfectly. On the left, in image A, that's a normal blood vessel. See the little gaps between the cells? Drugs can slip through those. Now look at image B on the right. In the brain, the cells are fused together with something called tight junctions. There are no gaps. This high-security wall is the famous blood-brain barrier. So the takeaway is simple. To get past this elite security system, a drug has to be highly fat-soluble. It can't use any gates because there are no open gates. It has to dissolve its way directly through the cell walls. So, our drug has crossed membranes, entered the blood, and navigated the body's highways all the way to its target. What a journey! But the grand tour isn't over yet. The body still needs to process and eventually get rid of the drug. So how does it say goodbye? And why does this whole journey sometimes look so different from one person to the next? We'll cover all of that in part 2. Thanks for joining me today.